For those of you who are taking attendance, the slide is in front of you. If you text FC 583 to 336-793-9317, they will count you as being present this morning. This morning I have the honor and the privilege of introducing Dr. Petty. He is an amazing physician. I had the opportunity and pleasure of working with him as a part of the house staff here. A quick bio: he went to UNC for medical school, went to Duke University for residency, Dartmouth for fellowship in medical oncology. I can't speak this morning. He's the director of the lung cancer disease team here, as well as he was the former director of the research program in internal medicine here. So it is my honor and pleasure to introduce him this morning. He'll be speaking on metastatic lung disease, preparing for the unknown. This time I'll call for Dr. Petty.
Great. All right. Thank you. Thank you, Brian. It was a joy to have you on service back in the day, and look forward to seeing more great things in the future for you. So I'll be talking about metastatic non-small cell lung cancer, and part of my overarching goal is to convince you that things really are different from where I started. So I've been treating lung cancer for 20 years, and what we've seen just in the last 5 years is exciting. And presents a new set of challenges that I'll try to explain. So no financial conflicts of interest. I will be talking about some off-label use of drugs that will hopefully not be off-label for much longer. Overall mortality rates. This is some old data, but the trend continues. When you look at the overall mortality in our nation, the number one cause of death in our country is heart disease, and the number two cause is cancer. Even if you just separate out lung cancer from all the other types of cancer, you'll see that it's actually the second leading cause of death from any cause in our country. So this is a major public health problem, highly relevant to everyone in internal medicine, and I appreciate you sort of being here to hear about it, because I know that many of you, in whatever subspecialty you practice or general medicine, that if you haven't diagnosed someone with lung cancer yet, you probably will, and you'll be in that situation of trying to have some conversations and trying to help your patients wrap their head around what's ahead for them. So it's a very prevalent disease that has had some real significant breakthroughs recently, and so I want to help you prepare for those discussions and prepare for you as you see my patients and in clinic, in the hospital, et cetera. So this is a common quote that I hear from my patients, and I've heard this for 20 years. So when I first started, the thought that I just want to live long enough to get to the next breakthrough was a little bit of a pipe dream. Honestly, it was something that I had to kind of correct with patients when I heard that that's a great thing to hope for, but that's probably not a realistic thing to hope for. Nowadays, when I hear this, it's something that I sort of acknowledge as, me too. I hope you do live long enough to make it to the next breakthrough. There's certainly no guarantees, but I'll show you that the breakthroughs have been coming more rapidly as the years pass. So I'm going to talk about a couple of cases, and I'll refer back to these during the lecture. So the first case is a patient of mine, 65-year-old, previously in excellent health, presented with chest pain and cough, pretty common scenario for me to see in clinic. She's found to have a lung nodule with metastatic bone disease on her PET scan. She had no major driver mutations, and I'll explain what those major driver mutations are, why those are important. And so she actually participated in a clinical trial, received 4 cycles of chemotherapy, and since she only had sort of a limited number of these bone lesions, underwent radiation to the sites of disease as part of this oligometastatic protocol. So this is her PET scan. One of the bone metastases was resected in the process with sort of biopsy-proven metastatic disease. Her lung nodule there in the left lower lobe. So that was sort of her baseline case. And I'll come back to her sort of long-term follow-up later on. Second case is probably the other end of the spectrum, not very healthy. A 68-year-old former smoker presented with chest pain as well, but also failure to thrive. He was very fatigued, actually presented for a second opinion after another oncologist told him that he was not healthy enough to receive any treatment. In a wheelchair with family all around, was found to be strongly positive for PD-L1, and so we had the tough conversation. Well, this is a new biomarker, there's a new treatment, and we talked about hospice again, sort of like the prior oncologist had, but with these treatments being so well tolerated, at least with the initial couple of doses, really not causing much in the way of side effects, he and I agreed to give it a try with a dose with the understanding that if he got sicker, we would switch to hospice. He was admitted with a pneumonia afterwards, did not appear to be a drug-related thing, was a true pneumonia, so thankfully didn't really have any side effects from the treatment, but at that point decided we would sort of move forward with hospice rather than trying additional medications. So, and I'll come back to his case later on as well. So for the talk, what I'm going to go through, I'll talk sort of the timeline of these advances that I've mentioned, go through a little bit of the biology. I'm not going to go sort of deep into the biology because we only have sort of a limited amount of time. And then I'll talk about some of the breakthroughs in immunotherapy, this oligometastatic radiation concept that I mentioned, and then try to bring it back to this issue that all of us will confront at some point as physicians, where you're seeing a lung cancer patient and trying to have some information about prognosis and guidance for people that are facing sort of the fight of their lives. So we'll spend the last half of the talk really talking about the prognosis piece and how I approach that in the current day and age. So advanced non-small cell lung cancer. It's not one disease. So I remember sort of meeting with Mike Sporn as I was a fellow, and he's a sort of a lung cancer basic science person, and he said, I think lung cancer is probably, at least 100 different diseases. You just look clinically at what happens with these folks. They've got a bunch of different appearances under the microscope, and you have some patients where, the treatments, seem to be helpful, or their cancer seems to be slow growing or fast growing. It just seems so diverse. Unlike some other solid tumors, it seems like there's just a huge amount of variability. And at that point, when he was sort of talking to me about this, none of it was known genetically. It was more just a sort of this clinical observation. We now know genetically, molecularly, some of the differences, some of the reasons that that the subsets of treatment responses and prognosis can be varied across this population of diverse cancers. So these highlight the ones that are felt to be, the majority of these are felt to be driver mutations. So I mentioned that concept before. So RET, ALK, BRAF, all these are sort of driver mutations. PD-L1 is not a driver mutation. It's not a genetic targetable error in the cancer cells. PD-L1 is a protein expression that alters the sensitivity of the immune system, the ability of the immune system to do surveillance for those. But I've included the entire population of lung cancer with the highlighting this PD-L1 negative group. This is sort of everybody else, no established driver mutation, and not PD-L1 positive. And the good news is we've had breakthroughs for all of these patients. So everyone in the group has had something that constitutes a major advance. And I'll go through those. Show some of the survival curves. Again, try to convince you that I'm not just talking out of my head, that these are truly important changes. But in this slide, I think what I just wanted to highlight is the pace, right? So EGFR was 2004, ALK was 2011. From 2015 on, it's been sort of a new approval every year. And these effective drugs, so the way you establish something is truly a driver mutation is if you block it with the medication and the cancer shrinks in a patient. You can do a lot of work in the lab, but that's really where you establish, in fact, these are driver mutations. And we've seen these FDA approvals of inhibitors of each one of these pathways for non-small cell lung cancer. RET and exon 14 are not approved yet. We're anticipating that next year. So historically, EGFR was the first in class of these targetable mutations. So like I said, I'm going to go through a little bit of basic science, but not much. So EGFR is a cell surface receptor that activates cell division. When the receptor is mutated, it becomes constitutively active, does not require any ligand to bind to generate that signaling, and apparently just drives cells through the cell cycle, also promotes angiogenesis and resistance to cell death. So you establish that this is in fact targetable by targeting it in patients. So the first set of studies that showed that this was a driver mutation and that we were going to be effectively able to help patients compared the inhibitor of this EGFR to chemotherapy. So there have been several studies in this vein that have looked at a pill versus actual cytotoxic chemotherapy. And in EGFR mutants patients, clearly the TKIs continue to win. So this is osimertinib versus chemotherapy. You can see these survival curves are very different in terms of whether they have brain metastases or not. Particularly, the benefit that's been seen in osimertinib over the other drugs is that it appears to be effective for the brain where other types of these pills aren't effective. When you look at the first generation versus now the third generation tyrosine kinase inhibitor, there have been even more advances. So the things to pay attention to on these survival curves, you can look at the shape, but you really got to look at the x-axis here, right? So we're talking now about 30 months plus. So we're following these patients for a long time on these drugs, and they're still doing well. So when you look at overall survival for osimertinib, it had not been reached actually, even out at 30 months. So that's better than it used to be for non-small cell lung cancer. For those who've treated this for years, I think you'll appreciate that. So EGFR, major breakthrough, drug approval, change in the practice for that subpopulation. So that was the first one to sort of fall into place. The second one to fall into place was ALK, and this one is also very exciting. So this is what's called a FISH probe. So when you look at ALK, it's a tyrosine kinase, and the way it gets activated is there's a chromosomal rearrangement. So you have that rearrangement event, and the tyrosine kinase component of that gene is then attached to a different gene so that it's expressed at a high level in a constitutively active kind of form. Hope that sort of makes sense. I just think the test is neat, and it makes well for sort of pretty pictures. But it's the way you test for this thing is you have a probe on either side of the tyrosine kinase, and if the gene is intact, those probes overlap, and you get this merged sort of color signal. And if that gene is broken, then you'll have the 5' and the 3' end on different chromosomes. So you see them separated. So this is a positive FISH probe testing for that ALK gene rearrangement. Nice thing about this particular test, it doesn't matter what gene it's rearranged to. If you see this positive probe, you know that it's been rearranged, and that was the FDA-approved sort of test for this. So, so what's the excitement? So this is the first data that really caused a lot of excitement in the field and actually led to the approval of the drug based on response rates. So what I'm showing you here is something called a waterfall plot. If you haven't seen one of these before, a waterfall plot shows each patient as a column. So every column there represents an individual patient. And what's shown is the change in the tumor dimensions. So if a tumor gets bigger, the column goes up. If a tumor gets smaller, the column goes down. And you stack them from worst to best, left to right. And what this waterfall plot typically looked like was not this. So typically response rates with frontline treatments are somewhere in the 25% range. For patients who are ALK positive and were given this drug, almost everyone responded. Almost everyone had some degree of tumor shrinkage to occur. And so at that point, even without a phase 3 trial, this drug was made available to patients. Phase 3 trials did sort of proceed and confirm the benefit to patients. But I just wanted to highlight this waterfall plot because this is how I'm going to show you some of those other drugs that are about to be approved, is with this sort of waterfall plot shape. So when you have a drug where almost everyone has their tumor get better, that drug is going to work, you know. It just, that's how the math kind of happens. So there have been new generation drugs. So crizotinib was originally developed as a MET inhibitor, had activity for ALK, but then, you know, once they saw this, there were better ALK inhibitors that were developed. Alectinib is the one that's really best in class at this point. And so when Alectinib was compared to that first generation drug, you can see significant benefit for this sort of later generation compound. And again, when you look at overall survival, you can see, you know, out at 30 months, things still looking really pretty good for these patients. So how do people feel, right? So that's one of the critiques is, okay, you've got these survival curves, you're showing me people live longer, but are people having good quality of life? And it's a really important question. And so it came up acutely, actually, last time I was on service with Sarah Moss and the rest of the gang that were on Hem-Onc A with me. We had a patient with lung cancer, lymphangitic spread of lung cancer, very short of breath, hypoxic, 6 liters of oxygen, couldn't hardly move without becoming more hypoxic. And they sort of ran down the outside pathology and were able to find that this patient, lo and behold, had an ALK gene rearrangement. So the pharmacist sort of worked with administration, you know, hospital administration, try to find a way to get access to this very expensive medication, and eventually was able to figure out how to get access to it. And she did it in part, made that case based on this study that she found. So this was looking at quality of life. So what happens when you put somebody on one of these medications? Do they feel better or do they feel worse? Well, they feel better. So this is the patient-reported outcome, quality of life metric over time. Up is better. So they feel better. They have improvement in quality of life that's sustained for, you know, this is 60 weeks, so at least more than a year that we're talking about of sustained improvement in quality of life. And their quality of life improves very quickly. So within the first sort of time assessment, you could see that they're actually already feeling better. So anyway, made this case. Her and Sarah and the whole team, they were able to sort of get access to this medication. The patient started the pill. Within 5 days, the patient was off oxygen and discharged home. So just saw me in clinic and is still doing well off oxygen. So patients can feel better. They can feel better quickly. And so in addition to helping people live longer, we're clearly helping them live better. So, all right, on to more precision oncology. So those two are the major ones that really set the stage for a number of other medications in other genes. So ROS fusion, so this is another one where the waterfall plot really led to clinical use and eventually did lead to FDA approval. But you look at that waterfall plot on the left, it's the same shape, right? You give the pill to the right patient and everyone gets better, except maybe, you know, 1 or 2 people. But almost everyone gets better. And so this genetic match kind of concept works for ROS1. It works for BRAF. So this is another combination that's now been FDA approved for non-small cell lung cancer patients. Dabrafenib, trametinib. So when you look at the change in the size of these lesions, again, you find a BRAF positive patient, you give them a BRAF inhibitor, everybody gets better. So still kind of have to pinch myself every now and then. It used to be like this, right? I've been doing this for 20 years. 20 years ago, right? This is not what we saw. So MET, exon 14. This one's really important to teach oncologists about, as you. So this is a story that's still kind of breaking and underrepresented, I think, within the community, but you'll be hearing more about it. MET exon 14 positive lung cancer is a horrible disease. These patients do much worse than the average patient if they're not treated with a MET inhibitor, and you know, survival on the order of a couple of months. You know, it's kind of like a small cell type aggressive behavior. Had a patient recently who'd been treated with chemoradiation, grew right through it. and then got put on a MET inhibitor and responded. So this is one where the data, it's not very common, and that's why there's not a lot discussed about it. But when you look at the shape of that waterfall plot, it's the same shape. When you have patients selected for MET exon 14, you give them the MET inhibitor, in this case crizotinib, which is not FDA approved, but when you give them the right drug, you actually see good responses, and the data are looking better and better. And there are now some next generation MET inhibitors right behind crizotinib in that space. RET, this one is very exciting. Just had a patient recently who I mentioned at the beginning that the concept of I just want to live long enough to get to the next breakthrough. So I just had a patient come and see me here recently who I've been sort of co-managing with a local oncologist, and we've been hoping to see something come forward in the RET space. And just this year at World Lung, the data were released about LOXO-292 showing this same sort of level of activity. So she's actually going up to get an expanded access protocol up in New York to get that drug. So that one is not approved yet. LOXO-292, very exciting. Anticipated it'll be approved in the spring sometime. NTRK, so this is FDA approved. So this was the New England Journal of Medicine paper showing that patients with NTRK fusions, regardless of what type of cancer they have, can benefit from an NTRK inhibitor. So this is the first time where we've seen this model, and you'll probably see more of it, where you just have a genetic cohort rather than a tissue-specific cohort. So a lot of these were actually pediatric patients who had NTRK fusions present in their cancer, but they're also non-small cell lung cancer patients intermixed. The sort of blue, sort of intermediate blue color is the lung cancer patients, and several of those did get put on the study and did respond. So we now have an FDA approval for, independent of cancer type, a gene-rearranged cancer with an NTRK inhibitor. So another advance, very rare in the lung cancer space, less than 1%, but we do find some folks with it. So those are sort of the main genetic breakthroughs that we've seen in the last couple of years. The other breakthrough you may have heard about, and I'm sure you've seen some of my patients in the hospital with side effects from, is immunotherapy. So immunotherapy is here. It's here to stay, and it's transforming the practice of thoracic oncology. So what is it? The lung cancer cells, as they develop, become very genetically abnormal. So over time, particularly in smokers, they accumulate all these genetic derangements. When you look at how bizarre the genome is in lung cancer, it's actually one of the most bizarre. So melanoma and lung cancer are the most genetically bizarre cancers, and they have the most abnormal proteins on their surface as a result of that. So your immune system should be able to detect weird proteins and attack cells that show those. But this PD-L1, the protein expression that pops up as these lung cancers develop, keeps the immune system from being able to recognize and attack those cells. We know this because when we block that one little protein, so the first demonstration of this was nivolumab. All it does is block that one little protein. You could see dramatic responses in patients. So you're just allowing the immune system to get in there and do what it needs to do. And the responses were impressive. In second line, it was better than our chemotherapy regimen, Taxotere, which was sort of standard of care at the time. And what was exciting about this is two things. The first is it's better than Taxotere, so you get approval, company's happy, right? But as an oncologist, when I talk to patients about treatment and about prognosis, which I'll get into more in just a minute, they're interested in median survival. That's how we sort of talk in medicalese. But they're more important. They're more interested in do you have something that's going to help me live for years? We never really had something that we could talk about that kind of longevity. And when you look at the shape of these curves, you can see, well, gosh, the shape of these curves, even at 2 years, look very promising for the immunotherapy. Some of those responses are lasting, gosh, a really long time. And we have now longer-term follow-up on that same drug. And when you look out 5 years, you can see patients alive 5 years. And these are folks that were phase 1 trial patients that had progressed on everything else, had their cancer go poof on immunotherapy, and 5 years later are still doing well. 16% of people, so not everybody. Not as good as we want to be, but certainly much better than it used to be. Okay, Pembrolizumab, another immunotherapy agent. So we just had the update from 5-year data from Keynote-01, which was the first frontline study looking at use of these medications. And what it showed was at 6 years, you have patients who are PD-L1 positive. You have, over 20% of people who are strongly PD-L1 positive still alive at 5 years. And so exciting. When you break it down by PD-L1 expression, so that's how we determine who gets this immunotherapy medication instead of chemo as a frontline treatment, is based on this PD-L1 expression. For folks with PD-L1 present in greater than 50% of their cancer cells, you can have 5-year survival of almost 30%. And then as the PD-L1 expression is a little bit lower in that 1 to 50% kind of group, you still have 16% of people alive at 5 years. So Keynote 189, so that's for PD-L1 positive patients. So that was a select group. Some of them didn't have very much PD-L1, but they still had some, and some had very high levels of it. The rest of the lung cancer patients that are PD-L1 negative. So that's basically everyone else. So I mentioned we had the groups of the oncogenic driver people, we had the PD-L1 high people, and then we kind of have everybody else in this PD-L1 negative group. So Keynote 189 included everyone regardless of their PD-L1 expression, and looked at overall survival. And what you can see is a really dramatic improvement when you added the immunotherapy medication to chemo, as opposed to just doing the standard of care chemo alone. So this is another impressive breakthrough. So, and these are all, it's all in the last 5 years. It's hard to keep up with. So again, how do people feel? This is important to us as oncologists, and been very fortunate to work with folks in the School of Public Health here at Wake Forest. We have an amazing School of Public Health here, one of the best in the country, and they have got several folks in there interested in lung cancer. So this was work that we did with Lori Steffen, who was interested in patient-reported outcomes. And so she did a patient-reported outcome study in folks on immunotherapy to see how their quality of life was, and was able to compare people getting the chemo with the immunotherapy versus the immunotherapy itself, and make some new observations. It's really the first study of its kind that'll be out in press here, hopefully within the next couple of months. So what she looked at in terms of the patient-reported outcomes included function as well as symptom burden. So, our patients it's not just a matter of adverse events and symptoms. They have lives, they have families, they have people that they work with, they have social function outside of the clinic, and she does better, sort of monitoring that probably than a lot of us with this sort of patient-reported outcomes approach. So she looked at patients with good performance status going into their treatment and poor performance status. So those are people who have a lot of fatigue versus people who don't have much fatigue at all. And when you look at that sort of pre-treatment performance status, you can see that there are significant differences in terms of physical function and in terms of role function. When you look at, she also looked at elderly patients versus younger patients and found some interesting observations there as well. Social functioning was actually quite a bit higher in older patients. So I think we're learning more about how our patients are feeling, and how our patients are getting on with the work of life while they're on treatment. So this kind of highlighted an impact of performance status in the immunotherapy space. Surprisingly, there's nothing in the literature really about that issue at this point. It's a huge unmet need. A lot of people are saying, regardless of whether someone has low performance status or high performance status, they should get access to the medication. That's been our approach, but we've, thanks to the work of a lot of residents and fellows, we've sort of looked at our data, and this is also sort of a manuscript in sort of accepted pending revisions at this point. So we've looked at our own data and said, okay, well, if that's the practice, how are patients actually doing? Is there still a role for looking at performance status in the immunotherapy era? And our data do, clearly show separation for folks that have high, good performance status going into it, they live longer and have longer control of their disease. Patients with PS2 and some patients with PS3. I don't know if anyone's kind of in the oncology space shuddering that we're sort of treating patients with PS3, but at this point we are, and we're still trying to sort out who in that group could potentially benefit. So this is just our retrospective experience. Tom Lycan has written a prospective study to look at this question, and hopefully we'll be able to learn more. In addition to just that sort of performance status, he's actually going to be integrating a geriatric assessment to get a more refined sense of when you say someone's tired or not tired, functioning well or not functioning well. What does that really look like at baseline? So we're anxious to see that one get up and running. Tom's been putting a lot of work into that. He's a hardworking man, for those of you who know Tom. So oligometastatic radiation, this was the last thing I really wanted to highlight. So what is it, and why does it make sense? So this is one of those things that just has some kind of general kind of makes sense when you just step back, not as necessarily as an oncologist, but there are many patients who have a small number of metastatic sites of cancer. They have stage 4 cancer, yes, but they only have a couple sites of disease. There are many folks in that situation. And when we treat those people with our standard approach, chemotherapy, targeted agents, whatever it is, there are a lot of folks that will only progress at the sites that you know of, that actually don't pop up with new sites of disease, potentially for quite some time. And so there was this, remember the conversation with Jim Urbanek in clinic, someone was being treated in private practice, and they were going to, he had a couple of spots, and they were just going to go ahead and do SBRT after his treatment of those spots. And, is that kind of crazy? I said, I don't know. It'd be better to do it on a clinical trial, but it does make some sense. And so these new radiation techniques allow for ablative doses of radiation to sites of disease with minimal toxicities to patients. They can treat not everything in the body. Eventually, you do get these overlapping radiation hotspots, and so you can treat, but potentially up to 8 sites of disease you can treat with ablative doses of radiation. So if someone only has a couple of sites, might make sense. So what is this oligometastatic approach? Well, our study was chemo and then BEMO. So we gave 4 cycles of chemo and sent them downstairs to the first floor, and they saw if they could radiate them. And if they could, if they had a response or stable disease, they went ahead and delivered SBRT to the sites of disease. And in our study, we then stopped. This was before maintenance chemo had been approved, and so we actually did not include any maintenance treatment beyond that in our study. MD Anderson and UT Southwestern did chemo, then BEMO, then chemo. Theirs were started sort of after the maintenance chemo approval, and so they sort of integrated that into their approach. So case 1, so this was a patient that I mentioned at the start, 65-year-old, metastatic lung cancer to the bone, treated with carboplatin and pemetrexed for 4 cycles, followed by radiation to her sites of disease. So this is her PET scans. So this was the lung tumor, sort of the small kind of left lower lobe tumor, and mets to the ribs, one of which was excised for biopsy to demonstrate her metastatic disease. So she had 4 cycles of chemo, radiation to her sites of disease, and there we go. And I continued to see her in clinic, and that was 5 years ago since she completed her radiation. So she actually has not had any additional treatment beyond that. All she had was the chemo, the oligometastatic radiation, and is now disease-free 5 years later. So she's, back in clinic. It's an exciting time when she comes by to visit, and tell her she's a little miracle, which she is. So, so we're still learning. So we published our experience from this phase 2 trial. This was one of the first prospective phase 2 trials really to have long-term follow-up, 5-year follow-up on our patients, and we actually did have 5-year progression-free survival observed in some patients who just got 4 cycles radiation and nothing else. And so that was exciting. Is the radiation actually helping? So one caveat with our study, we didn't randomize. Thankfully, the MD Anderson and UT Southwestern studies did, and so they're able to really dissect out, is it the radiation that's doing anything, or did you just get lucky with the chemo? The chemo's good, but it's not that good. The radiation clearly had something to do with this. So this is the MD Anderson study that was just published last year, or this year, sorry, 2019, that showed overall survival as well as progression-free survival with this approach. And the addition of radiation after chemotherapy improved both the time to progression as well as overall survival. And their overall survival was right around the same that ours was, around 22 months. So, there's still, this is one of those technologies that has not fully been integrated into practice. So our study was 22 patients. The UT Southwestern and MD Anderson studies were a total of about 40 patients each, so about 20 patients per arm in their studies as well. These are small studies, but highly statistically significant. So there are folks in the field still debating this. The next generation of studies is going to be one that will be run here. So Mike Farris has written a study where we'll use the modern sort of chemo immunotherapy backbone in those patients with a limited number of diseases, add in the radiation, and see if 2 + 2 = 10 or something. So it's exciting. Okay, so communicating prognosis. So prognostic awareness, and Carl Gray gave me some of these slides. I appreciate him and his work in our clinic. So prognostic awareness is defined as the patient's ability to integrate the likely disease trajectory, to weigh burdens and benefits, and to come to more meaningful goals consistent with their values. It's something that gets talked about at Grand Rounds, and this actually, it was a Grand Rounds many years ago when Kevin Peacock, one of the oncologists, gave Grand Rounds on prognosis. That really got me thinking a lot about how I do it, because there's a lot of concern, a lot of question about, well, how is that happening? How are people really discussing prognosis? Do they really understand what's going on? I don't know how many times I hear that. Do they really understand what's going on? So I wanted to give some perspective on this from the oncology clinic and try to explain sort of how I go about it. But this sort of prognostic awareness is a process, and patients can swing from unrealistic goals to more realistic goals. They may say, gosh, I would love to be able to, go scuba diving, and, they're on 4 liters of oxygen or something. Well, yeah, it would be fun, but they may go to more realistic goals. But, I just really want to go to, the kid's house for Thanksgiving or something. So they can swing from these realistic goals, unrealistic goals, and as they go through their treatment, there can be a period of time where they're really focusing on living well, but sort of passively aware that at some point they're going to die, And as they get closer to that point, that may come more into focus as they continue to try to live well, but this intrusive aspect of, the fact that they're at some point dying really comes more into view. I think that's a great framework, and I think I've seen that really play out in clinic. So one of the things that we do is try to help people with coping and support. Emotional, cognitive, behavioral, and existential approaches are all involved in clinic as we're trying to help people with that. So where does a prognostic discussion fit into that support? I think it does. And so I'm going to go back to case 2. This is the one that I presented that was sort of the other end of the spectrum. 68-year-old comes in with performance status 3 in a wheelchair, and not just in a wheelchair, really could not do anything. With his family, had been told by another oncologist he wasn't going to try treatment, too sick, was PD-L1 positive. We decided we'd give it a try. And I told him, if you don't get better, if you get worse on this, we've got to switch gears. And he got worse. So we switched gears, sent him to hospice after he was admitted for a pneumonia, and really we're not seeing a response at that point. So the follow-up for him, so I was pretty sure what this guy's prognosis was, right? I mean, I think we all were. There's a whole group of us that, this is absolutely, the right thing. I try to leave myself, this acknowledgement that even when I'm having someone go to hospice, if things change, I'm still here. I'll be happy if you do better than we expect. This guy actually, that's exactly what happened. So 3 months after he was discharged to hospice, I get a call from a family member. I'd really like to come back and get another dose of that Keytruda, the Pembrolizumab. Okay, well, I don't think that's a good idea. You got hospice is there; they're doing everything they need to do. I really don't think that's a good idea. Call back again. Okay, well, why don't you, if he feels up to come into clinic, he could come into clinic and we could talk about it, face to face. Well, this guy comes bouncing into clinic, not walking in. He's in jeans, a t-shirt. He looks like he's a new man. He's no oxygen, no nothing, and says, yeah, sure, let's do another one. I said, oh my goodness, so let's get a CAT scan and see what's going on. His cancer had, reduced dramatically, and so we said, okay, well, we'll give you a couple more doses. So he got, a few more doses and was able to have this sort of quality time and time with his family to do things, tie up some, relationships, things that were important to him. He did eventually die from his cancer, but he had a 1.5 years of just really outstanding quality of life that he wouldn't have had otherwise. So, okay, he's the exception, right? He's the exception, not the rule. But when we talk to people about prognosis, we do have to understand that we're not as smart as we think we are, and I try to express that to patients, but also give them information. So this is how I do prognosis discussions. First, and this applies to cancer, but I think other terminal diseases. First, is there a chance to cure this? Okay, whatever this potentially lethal condition is there a chance to cure it? If there is, I give a percentage. People do this different ways, and I think it's sometimes easier to say, well, for you it's either 100% or 0%, and I get that. I understand that for some people is a helpful coping tool, but I think at least at one point you should give them the actual percentage, because I don't think it's fair for people to start out on an attempt at cure when if the chance of cure is very low and not really understand that. So give the actual percentage. That's my approach. If the actual percentage is very low, I give the interquartile range, or at least offer to give the interquartile range for the people who aren't cured. So this was for stage 3 lung cancer. Well, it used to be 15% of people that be cured. Well, what about the people who aren't cured? Well, the people that aren't cured live somewhere between 10 months to about 2.5 years. That's how it used to kind of pan out. Okay. If there is not a chance for cure, I give the interquartile range to patients, and then I offer to revisit the prognosis discussion later on in clinic. Tell them I won't bring this up over and over again. It's not my goal to, every time you walk in, to remind you of your prognosis, but at any point as we get scans back, I'm happy to talk with you about it. So what is the interquartile range? So this is statistically the correct way to, one of the correct ways to describe the deviation of skewed data, which survival data are skewed rather than standard deviation. You can look at the interquartile range. So the median is the median. The interquartile range falls around that. It's the middle half of patients. So it's the 25th percentile to the 75th percentile. So I used to have a very easy time with this discussion. This discussion used to be very straightforward. All the curves looked the same. So this was a huge study in 2002, huge study, randomized all these different chemo regimens. They all looked exactly the same. They all looked, So 6 months to 15 months, it was true for non-small cell, and it was true for small cell. So it was even easier for someone like me with a short attention span. So, it was 6 months to 15 months was the interquartile range. And so I would have, I was having the same discussion probably, 6 years ago with patients. I was still relying on these numbers to try to help people understand what was ahead of them as they were starting this treatment and this kind of process. So this was the discussion. The middle half of people live somewhere between 6 months and 15 months. That's almost a 10-month window of time, and that's only accurate for half of people. So you have to, I found an incredibly useful way to do it, because you give them information, right? 6 months to 15 months. I would be prepared for that, to be in that middle half. 25% may live longer, 25% may live shorter, but I would be prepared for the middle half. That's a 10-month window of time. It's a huge window of time. And even that is only accurate for half of people. This may drive some, I don't know if people think this would drive folks crazy. I can tell you when I started doing it this way, patients really appreciated it. And I asked them about it as we were going through it, and they told me that it was really helpful for them to get this kind of information. The truth is, I don't have a good way to tell who's who. When you read a lot of stuff about prognostic discussions, they say, well, let's get more accurate. Let's drill down. Let's tell people, don't tell them you don't know. And I agree, don't tell them you don't know. But if you try to nail it down to, it's going to be really close to whatever that number is, you're going to be wrong 100% of the time. So if you can present information that's accurate, that's informative, and gives the informative lack of accuracy, lack of precision with it, I think it's really helpful. So it's how I would want to hear the information if I was a patient. All right, so the good news, prognostic discussions were easy back in 2005. The bad news is the outcomes weren't very good. Nowadays, instead of just giving either carbotaxol or carboetopicide, we have this whole paradigm, and this was 2018, and even since 2018, this paradigm has gotten more complicated. The decision-making process I have to go through, right, to pick the right treatment for the right patient is becoming more complicated. So is all that complication worth it? So I'm going to show you a series of slides, and I'd love to get feedback from folks afterwards. So this is that historical data with chemo. This is that ALK positive study, right? So the historical data on the left, and what I did is I chopped them so that they're all 30 months and made them about the same height. So even though they're not comparative head-to-head studies, this is what I used to do. This is what I'm doing now, right? This is how my patients are doing now. I think you can, hopefully you can appreciate that's really different, right? Okay, that's ALK. EGFR, same thing, sort of chop it at 30 months, about the same height. Okay, that's what it used to be. This is what it is. Dramatically different. PD-L1 positive. So our PD-L1 positive group is a huge population, actually. We have a lot of people that are greater than 50% PD-L1, and the majority of folks are greater than 1%. So this is the greater than 50% group, 30 months, still haven't hit median survival. For the greater than 1%, we've hit median survival, it's about 2 years. So I have a little bit different conversation with the low PD-L1 group, but still, it's a challenging conversation now. I used to use the interquartile range, right? I just showed that, 75th to 25th percentile. How do I do that now? It's a new challenge for me in clinic, and so I want to give people information. So this is how I'm doing it now. How do I tell them middle half of patients? I can't tell you middle half of patients. Are any patients possibly, potentially down the road going to be cured with these immunotherapy treatments? I don't know. I don't bring it up, but I don't have a straightforward answer. It's possible there could be some people, and I'm not the only one saying that. Sort of all over the country, people are giving a head nod. Can't say it's impossible at this point with immunotherapy. So the way I describe it to people that are in that group, EGFR, ALK, PD-L1 positive, in clinic, more than half of people live 30 months, and we don't know how long they live, but we do know that more than half of people are living longer than 30 months. I do try to, again, provide information about the variability. So 20%, there's still 20% of people that aren't going to make it a year. So there are still people that don't do well with these medications. Thankfully, it's the minority, but they are out there. And just like before, I can't tell exactly who's who. Well, through the good and the bad, we can revisit the prognosis at any time. So if someone gets treatment and they have progression, I want them to know that they can come back and revisit that because they're not in that group anymore if they have progressive disease. And this concept of new medications are being developed, and we will try to keep our ear to the ground for the next breakthrough as we go through this. When you look at the breakthroughs happening, new approvals every year, every 2 years, and a prognosis greater than 3 years, the way things are looking, it's possible there will be a relevant new medication for the patients coming down the pipe. Okay? So with that, I wanted to just say a couple things about supportive care. Talking about all these medications, things that we can do, how we can treat patients. I have a lot on my plate in terms of the genetics and the protein expression and this. When studies have been done that include a palliative care physician plus an oncology physician, We know that the overall survival of patients is actually better if they have access to a supportive care physician, someone who is solely focused on their well-being and not consumed with the oncology piece. The reason I sort of saved this part for the end is that there are a lot of people in sort of supportive care, and there are a lot of people who are providing some sort of medical supportive care in whatever subspecialty discipline you're practicing to my patients. So there's dedicated palliative care physicians, but a lot of folks are asked at some point to sort of help care for one of my patients with lung cancer. I think at Wake we do a great job of that. When you look at how our outcomes compare to other cancer centers, we actually do a lot better, and it's the same chemo. So I think a lot of it has to do with the medical care that's being provided here, and so thank you for that. So this, for those that can't read tiny little print, this is no palliative care. This is palliative care starting within 30 days, sort of within the first year of care for a patient. And Dr. Buckenheimer will be doing this soon, so you make a big impact. So, last quote, this is my last slide. One of my patients, just recently, we have a 5K every year in Greensboro for lung cancer, sort of our attempt to usurp the Comans. And every year it's really cold. I mean, it's freezing cold. Christina can vouch for it. You can have a perfect, 60-degree weather all year. The 5K comes around, it'll be 20 degrees, snowpocalypse, early November. So it's some sort of hardy souls that keep showing up for this. So one of my patients, and this was a public sort of presentation, so there's no sort of HIPAA whatever stuff, but she was speaking to the group, hundreds of people sharing her story. And so she put a lot of thought into this, and this kind of resonated, I think, with me and with a lot of the other patients there. So I'm not one of those people who finds much consolation in everything happens for a reason. I think we've all seen some truly bad things happen to good people. But this diagnosis had some unexpected blessings for me. It's taught me to live more intentionally. So anyway, she's a great person, great patient, and I wanted to just encourage all of us to try to live more intentionally. So I'd like to thank all the collaborators that have helped with the studies that are showed some of the sort of Wake Forest studies that have been published, in the process of being published, and some other studies that are in development. So just appreciate the help of all the folks in medical oncology, radiation oncology, pulmonary, palliative care, and then collaborators. Just as a plug for mentoring, some of the great joys are seeing mentored people go on and be successful. So Jim and Lori are, have their independent research careers now up and going, and continue to be great collaborators that trained here and started their research careers here. So anyway, with that, thanks.
Any questions or comments?
Thanks. Thank you, Jeff.
Yeah.
Wonderful overview and presentation. I was curious, how often do you find patients with multiple of these drivers, either initially at diagnosis or upon progression? I know there's some conversations that happen in top clinic about, do we retest? Are these patients having new drivers? And what do you see there?
Yeah, so at the outset, it's pretty uncommon. There's not a lot of overlap. So when you have someone who's initially diagnosed, there's usually only one true driver present. At the time of progression, sometimes people will have had a great response for a period of time, but then become resistant to the drug. And at that point, it's not uncommon to find a second driver. And so that's why we retest at the time of progression, is try to find those things. So yeah, good question. Yeah.
Jeff, thank you for a wonderful talk. As a representative for palliative care, I wanted to let you know it's been an honor for us to be able to work with such a phenomenal group in the Cancer Center, and really to see the benefits of true collaboration between palliative care and all of the other providers for these patients. So thank you for such a wonderful talk.
Well, thank you.
Jeff, for that big circle you showed of non-small cell lung cancer, and then the small circles with the new drugs that were approved over the last few years, what % of patients fit in one of those small circles? What, if you add up all the small circles, how much of the big circle does it fill up?
Yeah, so this is, the small circles all together add up to, if you exclude PD-L1 and you just look at the genetic small circles, you add those all up and you get to about 15% of the total population. So we see these genetic drivers, but these drivers are common in non-smokers. In our population, there's a lot of tobacco. So this PD-L1 group is equal in size to the others combined. So we have about another 20%, potentially 25%, somewhere in that range, that are strongly PD-L1 positive, greater than 50%. So this altogether is maybe half of the group, and then the PD-L1 negatives are the other half. So, yeah.
So, Jeff, that was absolutely fantastic. I was wondering if you talk a little bit about the cost implications of some of the targeted therapies and the immunotherapies, and the degree to which these drugs are covered by, third-party payers.
Mm-hmm. So the total cost of treating someone with Pembrolizumab, it was one of these sort of back of the napkin kind of calculations with the pharmacist in clinic, somewhere around $1.6 million probably for total cost to treat one patient for 2 years with Pembrolizumab, which is considered a full course of treatment. So it's not cheap. It's not cheap, and we have to be smart about it. One of the things with this oligometastatic treatment is there may be a subpopulation that we can treat cheaper. We did nothing else for those folks other than the oligometastatic radiation. That's about as cheap a treatment as you can get, is what our original Wake study was. So I think there are some folks where we can accomplish great things with much less expensive treatments. It's hard to get those things funded, but I think they're important, so we'll continue to try to work towards that. The pills are a little bit cheaper, but patients take them for a longer period of time. Yeah.
So you were right, I am jealous. As a leukemia physician, I used to always say, well, at least I don't treat lung cancer.
That's right.
Thanks for taking that away. So one question I have for you is, you're showing with these targeted agents as single agents, these median progression-free survivals or overall survivals over 30 months, with a tumor type that's supposedly highly mutagenic, has the highest burden of mutations, genetically heterogeneous, and yet in a disease like ALL, Ph-positive ALL, which is sort of a classic driver mutation, and with a single agent TKI inhibitor there, our median OS is 9 months, maybe 10 months, before the tumor sort of rewires itself. Is there anybody looking at why there's such stability to inhibition of a single driver in such a high mutagenic tumor?
Yeah, it's a great question. So when EGFR first came out, William Powell was the guy that discovered T790M. He and I were sort of fellows at the same time. We were comparing notes. They'd just come up with whole genome sequencing at the time. That dates me a little bit, but it was brand new. And so they were doing whole genome sequencing on EGFR mutant cancers, and he said, gosh, this is just crazy. They look so normal. So the high mutagenic burden is present in subsets. So these EGFR mutant subsets are actually not that highly mutated. When you actually drill down to their genome's pretty normal. It's these PD-L1 positive folks that are tending to have the higher mutation burden. A little bit of data sort of coming out, sort of teasing that out more, but by and large, these are the non-smokers with low mutation burdens in their cancers, and these are the high smokers with high mutation burdens in their cancers. So thankfully, advances for both groups here recently. But yeah, good question. Yeah.
Hi, Jeff. Excellent talk. Tim, you can still say you don't do pancreatic cancer, and then you'll do fine. Yeah, you should have that as a backup. So, interesting work with the public health group, Jeff. I may have missed, but in pancreatic cancer, we have a 4-drug regimen that is superior than 1-drug regimen. And when we look at quality of life, there is no worse impact in quality of life than cancer progression. Actually, when they do the EORTC, the quality of life drops in parallel with disease progression. So the message in pancreatic cancer is easy. There are side effects, but guess what? There is no worse impact in your quality of life than peritoneal disease with bowel obstruction. There is no worse quality of life than cholangitis, duodenal obstruction, gastric outlet syndrome, and so forth, associated with cancer progression. Did you look into that with the immunotherapeutic approach in lung cancer?
No, this was more of a cross-sectional survey, so we didn't have people who were progressing at the time that they were doing the survey. We were looking at people who had been on immunotherapy already, and we were looking at their symptom burden and social function sort of at a snapshot rather than after that cancer was moving forward. But I think the lung cancer data certainly supports that from the chemotherapy era. Chemotherapy has side effects, but the side effects of cancer are worse.
All right, everyone. In the interest of time, we're going to kind of wrap things up. Thank you, Dr. Petty. Thank you all for coming. This was an amazing talk.
Great. Thanks, Brian.